this is the fourth Advanced Pediatric Endocrine Symposium, which we are organizing. The first one in the form was actually started off in 2017. And since then, many of the faculty, all the guiders, everybody is the same. And we are continuing with the same team for quite a long time. It's been really a pleasure in that regards. Now, when we had initially, we were always thinking that pediatric endocrinology is a rare group of disorders, which are complicated, which are cumbersome in terms of workup and very expensive treatment. So people used to, in a way, shrug away from pediatric endocrinology, don't want to go into this field, and everybody was very scared, so to speak, about that. Now, when we thought about this, what we realized that there are three issues in any health problem: awareness, accessibility, and affordability. Now, everybody says these are not affordable, but we believe that awareness actually is the elephant in the house. And if we increase the awareness amongst the general public, amongst the physicians, we would be able to improvise the care. And this was the motto by which we established the pediatric endocrine group, and then we started the Growth Society working in that direction. Now, if you look at the pediatric endocrinology burden in India and the specialists who are available, what we see is that we would probably have a handful, maybe 100 will be the overall, maybe a overestimation also at the moment, but now with more fellows, the numbers will increase. So this still is a very, very small number for the burden of population for type 1 diabetes, growth hormone, thyroid, all those things. And pediatricians are approximately in much bigger numbers. So we need to really have a bridge in which things can improvise and connect between the two so that we can have a continual good quality care in everywhere. So currently pediatric endocrinology is focused and centered in few cities. Some cities like Bangalore will have maybe 20 people who are there, but then some whole states will not have people who are trained at all. So we need to have more wider exposure, and that's why it's very important on part of everybody. And it's responsibility of us pediatric endocrinologists, and ISPE has been working a lot in that to really spread the message of pediatric endocrinology. We have been doing a lot of programs right from 2011, and you can see many of the same people have been involved, and they have always been our inspirational force there. We started with our first program in 2011, and then since then there have been hundreds of programs which were done in terms of workshops, in terms of advanced courses, practical courses across the country, which we have been conducting. Now, this basically is the third Advanced Pediatric Endocrinology Symposium. And from there, what we realize that if we keep on doing workshops, how much time can we spend? Like, it's not possible to do workshop everywhere. So we started off with social media in terms of YouTube platforms. And from there, a large number of people actually were able to access, and you don't need to be there all the time. They can access that. Then we started an on-site fellowship program, and we have got Chetan from the first batch, Neha from the second batch today, who are there. We until now had 11 fellows who are being under part of training. Then what we realized is that if you want to have a structured training, we need to have a web-based program. So we started with a MedEClasses platform, which provides a lot of information, started with books, and then to practically use that knowledge, mobile applications were developed. So we have got a lot of e-learning videos available on YouTube with huge number of views. This is something which is available covering entirety of pediatric endocrinology. We have got structured learning program under our learning.growsociety.in. We also offer a 2-year hybrid program for fellowship and a 1-year hybrid for diploma. We had got a lot of people who come to us every 6 months for a week. They learn the exam. So it's a very intense process. So we are going to have some of the announcements about the results of the fellowship program, the first one. We conduct a lot of online courses, pretty much 3 to 4 every month. So it's quite intense. We have got a number of publications which are there. And what we are going to launch today is the second edition of our pediatric endocrinology protocols, which is a completely updated book about latest protocols for pediatricians, pediatric endocrinologists, and we'll be releasing this today. One major advantage we wanted to take was with regards to our application, because that will provide much easy access to use, because what you learn, if you don't use it immediately, you will forget and the errors will come in. And these applications were developed, and they are now become the most popular endocrinology application across the globe. And we have done a lot of publications regarding the growth interpreter, which allows practical interpretation of growth. We have got the obesity interpreter, which has been validated. We have got puberty interpreter, which allows interpretation of puberty, for thyroid, for DSD, and all of them have been presented and they are in publication in different places in that regards. Now, what we have done now is a very interesting thing, which is actually a combination of all that we have done. This is a bone age assisted interpretation of growth. So all the pediatrician would have to do is to put some basic data. It includes information like birth weight, sitting height. So all the rough things that we anyway write down and we measure, we just write the Tanner staging, we match it, we have the bone age interpretation. And as soon as this is done, it is using all the algorithms which are available. And based upon this algorithm, we will have a lot of information, data points will be available. So you will have specific charts, bone age interpretation, lot of parameters, and this will predict the likely diagnosis, most likely investigation. And we are validating this now. So this will be a very valuable tool for screening pediatric endocrine disorders. And hopefully, so this is how the result will look like. So you will have charts and you will have table which has got a lot of interpretation, and then we'll give you the final interpretation as to what is the likely diagnosis in that regards. We are coming up also with a personalized intelligent EMR, which is going to basically decide based upon specific conditions, give the inputs for every condition. And once you choose those conditions, you get the data, you will get an output which will guide in terms of evaluation, assessment. So only those which are relevant will come up on that drop-down menu. And based upon that, you will have a state-of-the-art evidence-based algorithm-driven approach which will come and analysis will come. This will provide information in the form of also a nutrition chart. So a 7-day meal plan will be there. So we had got, recently we had this on-site course in which we had got large number of people who had come from across the country, and we had around 200 patients who were seen over the last 3 days. And we had a very intense discussion which was there. So this Advanced Pediatric Endocrine Symposium, we're going to cover a lot of aspects of pediatric endocrinology. Diabetes, pretty much type 2 diabetes is something which is going to be very, very important from that perspective. And why it is important to really diagnose type 2 diabetes properly is highlighted by this case. We had this 16-year-old boy with polyuria who presented with hyperglycemia. The HbA1c was high at 10% and he had ketosis. So he typically presented with the ketotic diabetes, DKA, managed with insulin. And then somebody thought that, okay, he is slightly obese, that the family history. Now everybody says type 2 diabetes is very common. So we should think that this is type 2 diabetes, and metformin was started, insulin was stopped. Now, do you agree with this regimen that this child who is obese, maybe has a family history, you stop insulin just by assuming this is type 2 diabetes? So this is not the right practice. So what happened? This child then presented later with diabetic ketoacidosis and then was found to have GAD positive. So the big message this case gives is that unless and until you have excluded immune diabetes using at least GAD antibody, you should not make a diagnosis of type 2 diabetes. And that's very, very important. So we know that now we have a greater number of adolescents who have type 2 diabetes. So this I'm talking more in terms of adolescent perspective. We need to be aware about how we manage and how do we diagnose these cases. Now, why are we bothered about type 2 diabetes in adolescents is that they have a much more aggressive disease. A larger number of these people will have complications, nephropathy, hypertension, microalbuminuria, Dr. Rishi will talk about right at diagnosis. So they are very different from type 1. And studies have shown that they will have a very rapid progression in terms of diabetes. So they will lose 10% of their beta cell mass every year, as against 7% which the adults lose. So they have a much likely chance of progressing very rapidly. And there are very few options available in terms of therapy, which is there. So I'll talk about these issues. And all of you should go and have a look at the ISPAT guidelines, the current guidelines, which I'm trying to refer also in certain scenario. So we'll start off with the first case, 12-year-old boy with obesity. He has a BMI, which is plus 2.2 SDS, has acanthosis. There is a family history of diabetes. Now, how do we screen this child? And that's the question. Now, if we go by the ISPAT guidelines, the diagnostic criteria are not different from adults. So typically you go for an oral glucose tolerance test. So fasting blood sugar, and then after a 75-gram glucose, and you also talk about HbA1c. Now, if we compare these three values of fasting versus HbA1c versus a glycemic load, I would say that HbA1c is something which we should not use alone. Many patients come to us with 5.7 to 6.4 labeled as pre-diabetes. When you do a proper evaluation, you do not find that there is a good correlation. So in a lower range, as Riddhi was talking about, HbA1c may not be a very good indicator. So what I am talking about is that fasting sugar, if it's high, it's a very, very specific pointer that there could be a definite dysglycemia, which is there. And after glucose load also will tell you what will happen if you eat a lot. So fasting is like, if you look at, if it's high, it means that even without doing anything, your sugars are high. Post-meal or 2-hour value will tell you if you have a feast like this, what will happen to your sugar. And HbA1c is a crude marker in between. So HbA1c definitely, if you are thinking of, you should only be doing using the assays which are standardized against the DCCT database. So that's another important factor to look at. Now, very importantly, what they say is that you don't just look at sugar. You have to look at blood pressure. You have to look at hypertension. You have to look at steatohepatitis. Along with that, you also look at sleep apnea. So all these factors also have to be assessed in that regards. Now, in this case, we found a fasting of 96, which is normal, HbA1c of 5.3, and our glucose load 123. So what do? Do we stop monitoring here? No. The very important message is that we need to keep on follow-up. And our study also suggests that these metabolically healthy, quote unquote, what we call as metabolically healthy, 40-50% will progress to metabolic complications within the next 2 years. So what they recommend is that every 3 years at least, you follow up and measure these profiles time and again in that perspective. The criteria we all know of the fasting, the impaired, the pre-diabetes, and these criteria are pretty much there from that regards. You should do a 8-hour fasting, glucose load is standard. So these are the standard criteria which are laid down by the ADA. So very importantly, we will now move forward to this case again, that once you have diagnosed diabetes in a child who looks like obese adolescent, do you really say this is type 2 diabetes? No. And for that, we need to understand that type 2 diabetes and type 1 diabetes may be very difficult to differentiate in this age group. So while a pubertal onset with a family history in the setting of obesity, acanthosis, and lack of ketosis will indicate a high possibility of type 2 diabetes, the only most important discriminatory factor, if you look at, is the autoimmunity. So unless you have done a GAD antibody and GAD antibody is negative, you should not really diagnose somebody as a case of type 2 diabetes. This is a big message, and we saw a couple of cases exactly like that in that perspective. Now, what is the importance of autoimmunity versus C-peptide? So the major role of C-peptide is to exclude type 1 diabetes. If your C-peptide is high, you pretty much say, okay, it is unlikely to be type 1 diabetes. While the major role of autoimmunity is to rule in type 1 diabetes, if your GAD is positive, this is type 1 diabetes. I think that's how you should look into that. There is a term of obese individuals who have quote unquote type 2 diabetes with autoimmunity. These individuals tend to have a lower beta cell reserve. They have less metabolic complications and would need insulin. So obesity is not a factor to decide about in terms of deciding type 2 diabetes. It's the autoimmunity, which is the major factor. So now this is our algorithm that we use. So anybody who is after 6 months, particularly in the pubertal age group, if there is no decay and the insulin requirement is less, you look at GAD antibody. If it's absent and the child is obese, we consider that as type 2 diabetes. So obese, adolescent, not requiring insulin, GAD negative, this is type 2 diabetes for you in that perspective. So now this is what the recommendations are, and what they clearly say is that it's very important to have the negative islet autoantibodies, which is a major criteria which has come from the ISPAT guidelines as well. So insulin should have been continued. We have developed a diabetes interpreter, which basically looks into all these clinical parameters to classify diabetes and validated in terms of our study. And this was presented by Pratik in the ISPAD conference on oral presentation, which validates that it's a very good way to differentiate diabetes. Now we'll move forward. We have a 9-year-old girl with obesity, HbA1c is 6.5, and sugar fasting is 90, and 2 hours is 120. So this is a question. Now this is where HbA1c may cause confusion. So I would definitely not label this child as diabetes right now, because I know there's a lot of variation with HbA1c. So best would be to follow up in this scenario. And what we also need to look at how this HbA1c was done. So if it was done using a point of care test, we should better repeat with a standardized assay. And in that perspective, we found that this was normal. Now we need to follow up, and on follow up at 1 year, the child actually progressed to diabetes. There was fasting of 128 and 2 hours of 230. Now the question is, what do we do in terms of therapy? So over the next few slides, I'll focus predominantly in terms of treatment options which are available. And we always say there were only 2 options available as far as type 2 diabetes is concerned. We had the last session, I think 5 years ago, we talked about metformin and insulin. That's pretty much there. But now, as we speak, new drugs are getting available. So what are the options? We can use metformin, which will cause a sensitization of the liver. It will basically cause decreased hepatic glucose production. We got TZDs, which I think there's no one will think about them. They will cause weight gain, bone issues, so not for children. We can think of very important group of drugs, which are the GLP-1 receptor analogs. These are basically the incretins. Now, what incretins are is that whenever you have a meal, they are secreted by the duodenum and they go to the brain and tell, okay, don't eat anymore. They go to the stomach, delay the gastric emptying, they increase the production of insulin and they inhibit the production of glucagon. So they work on multiple pathways, and their analogs clearly are a good way forward in terms of diabetes management because they will cause weight loss and decrease appetite as well. You also have DPP-4 inhibitors. So we look into their evidence, which increase the half-life of these GLP-1 receptor analog, GLP-1, which we'll see how they work in children. Alpha glucosidase inhibitors basically decrease the absorption from the intestine, from the gut basically, and they are very mild agents. Most of us won't find them to be very efficacious, probably around 0.5 HbA1c maximum. One group of drugs which has really changed the way adult practice is with regards to type 2 diabetes is SGLT2 inhibitors, which basically decrease the renal excretion, reabsorption of glucose. So what they are doing is that they will allow glucose to go out of the urine. If you are losing glucose, your load comes down. Theoretically, you will lose some water, you will lose some sodium. And very importantly, in adults, it's been clearly shown that it has a cardio and a renal protective drug. So this is one agent which is really now becoming part sacrosanct after metformin in adults. So everybody is using this drug now, right, left, and center. I would say, and of course, the GLP-1 receptor analogs are also coming up. So how do they match up in children? And of course, insulin is a drug which is always available. So we'll talk mainly about these 3 drugs. So metformin is being indicated from a long time, above 8 years of age, especially the HbA1c is not very high. But if you have a child who has type 2 diabetes, whose sugar levels are high, in that regards, in the beginning, insulin is the primary therapy. And there is a transition to metformin once there is a gradual improvement. So we'll go one by one. Metformin is basically a MAP kinase inhibitor. It acts as a peripheral level as well as hepatic glucose production. So it is very good in terms of inducing mild weight loss. It is pretty much the first drug of choice in type 2 diabetes in all ages. You start off with around 500 milligrams. You should know that there will be a GI side effects which are going to happen. So you gradually build up to 2000 milligrams. Nothing beyond that 2000 grams, you will not, 2 grams, you won't get much benefit. Always give vitamin B12 because you will be losing B12 and that is going to cause a lot of neuropathic features which may happen. Very importantly, in patients who have a compromised renal function, a high level of ALT, or rarely if you have a mitochondrial disease, you should avoid this. And if you are on metformin, the child develops a sick day, stop metformin immediately. It should not be used with contrast or surgery. So these are some of the basic factors to think about when you think of metformin as a therapy. Now, is metformin going to really sustain a glycemic control? And this is the study I was talking about. This was the Today study, which was a landmark study as far as type 2 diabetes is concerned. And what they found was that metformin will not sustain the effect over time. And they, at that time, thought of rosiglitazone, which is now nobody will use, which is a thiazolidinedione, to improve. So what they found that after 4 to 5 years, metformin is not going to do your work and you would need to add some other agent. So progressiveness of type 2 diabetes in adolescents was established by this study. So we need more agents to have durable control. So one option is insulin, of course. So you use a basal insulin. You can use a degludec or a 2GO, or maybe once we have the icodec available, that will be once a week preparation. That will bring down your fasting and your sugar control will be better. So this is the way forward. Now, a few words about two important molecules which are now emerging and have been FDA approved as far as management of diabetes in adolescents is concerned. One is the GLP-1 receptor analog. So as I said, it has got 4 different areas of action. Increases insulin, decreases glucagon, decreases satiety, and also has an effect on gastric emptying, plus reduces weight. So it's a very, very good drug from multiple factors. It has got multiple effects, and the drug which was first approved in children was liraglutide, which is given once daily, and it can be built up gradually. It causes around 10% weight loss, which is there. The other options include weekly preparations like dulaglutide, exenatide, and semaglutide, which is now also available as an oral preparation in adults. So now if we look at these things, when should we avoid? Rarely, if there is a pancreatitis or there is a medullary carcinoma thyroid, you should avoid it. So the LEADER trial, which really led to the FDA approval for liraglutide, showed that this was a good drug, both in terms of reduction in HbA1c as well as reduction in weight. So this is a good agent, but again, a daily injection. So this is something, and a costly daily injection will limit its use in children. Now, once weekly dulaglutide has also been used in around 150 patients. It's again an easier one. So you give the injection once a week like Trulicity that's available, which will cause a weight loss as well as improved outcome. We have seen many patients who are on insulin. Once you give them once weekly dulaglutide, they will be off insulin. So this is a very, very good drug, I would say, but it's expensive. Maybe will cost around 8 to 10,000 rupees a month. And they may have side effects in terms of gastrointestinal symptoms. So this is an agent to watch for, a good one. There is now an oral semaglutide, which is available largely from the adult data, not yet approved in children. So this is a pill, a peptide you can take orally. So this is some smart technology by which you can take the semaglutide and it will work. So this is going to be a good drug to think of in children. You start off with low dose and build up gradually. Again, cost will be an issue, but I think this will be the work to watch out in children subsequently. What about SGLT2 inhibitors? So these drugs basically are causing decrease the reabsorption of glucose via the sodium glucose link transporter 2 in the kidneys. So it is causing more loss of glucose. You lose more glucose. If you lose 50 grams of glucose, your burden becomes less. You are going to also have a better effect on weight loss, reduce fat, and this is one class of drug which has shown cardiac benefit. And Dr. Rishi is really fond about the renal benefit that is there of this group of drugs. So this is a wonderful drug from an adult perspective. It is now recommended for heart failure without diabetes. It is recommended for renal insufficiency without diabetes. So this is some drug which is probably coming up as a big drug in that regard. So options are empagliflozin, which was the original molecule which showed the cardiac benefit. Now we have canagliflozin. Dapagliflozin is now available. There are hundreds of preparations available. The cost has become really down. So this is one agent which will be cheap, oral, good response, cardiac benefit. Now remember, these adolescents at 16 years, what will be their cardiac complication 25 years later? So this is going to be a big issue, cardio-renal. And if something prevents that, this is the right age to act. So I think this will be a good drug to look at. Of course, really, they may cause 5% cases may have lower urinary tract infections. If you give somebody who is insulopenic, you may cause euglycemic DKA, but this is very, very rare from that regards. And these things have to be looked into. Now, there are a couple of studies which have been published. One is about dapagliflozin, which has shown a reasonable improvement in terms of HbA1c in the setting. And this is some drug which has been shown to be quite effective. There is a very interesting study which has now been published recently, the Dynamo study, which was published in the NEJM quite recently. And this study is really showing that the use of empagliflozin in adolescents 10 to 17 years reduces weight and reduces HbA1c. So this is a group of drug which has a significant potential. So I think we've got the reprints also, so all of you can go and have a look at this. Is very recently published. And they also compared this to a DPP-4 inhibitor. And what they found was that SGLT2 inhibitor was good, but DPP4 inhibitor was not. So this is something which we have to look at. And very recently, just around 10 days ago, FDA has approved the empagliflozin now for the use in adolescents. So based upon this Dynamo study. So this is very, very good data, I would say. So we have got a good option. The preparations are available with metformin. So I think once we start using this will be a good drug to use in adolescents. And this is something which is there. What about DPP4 inhibitors? So of course, they are wonderful drugs, particularly being weight neutral, less risk of hypoglycemia, and they've been used a lot in adults. But the problem is whether they are suited for obese adolescents who have got many other scenarios. So the studies which have been done in the setting of the pediatric population with sitagliptin or linagliptin have shown to have limited effect. So sitagliptin, which was a wonder drug in adults and which became a multi-billion-dollar molecule, was found to have very limited effect, around 0.2% difference in HbA1c. If we talk about SGLT2 inhibitors, like 0.8 to 1, that is a standard sort of a reduction. This causes only 0.2% reduction. So this is non-superior. So it has no benefit pretty much. So we are not thinking of DPP4 inhibitor. And I talked about linagliptin earlier also. So probably DPP4 are not a good choice in this age group. So now what options can we use? Metformin, of course, remains the number one choice. Insulin, especially in the acute cases. GLP-1 receptor analog, especially once the oral preparations come into the foray. And SGLT2 inhibitors. I would say a combination of SGLT2 inhibitors and metformin will go a long way. It is easy, oral, cheap, safe relatively. So I think this is something which will go forward in that regards. At the moment, we will suggest a protocol that if you have a non-osmotic presentation with the HbA1c less than 8.5, start metformin. If there is improvement, continue. No improvement, think of a basal versus GLP-1 receptor analog, or maybe now a SGLT2 inhibitor added at that point of time. If there is an osmotic presentation with the HbA1c, which is more than 8.5%, start with basal insulin and metformin, and then you can add a GLP-1 receptor analog or a metformin. If the presentation is, of course, with DKA or hyperosmolar state, you have to start insulin. Do not add metformin during ketosis. Only after the child is better, you start and follow from there. So key is very sick child, start with insulin. Don't bother it is type 1, type 2, start insulin. Milder disease, you can start with metformin, and maybe SGLT2 inhibitor will be the way forward in that regards. So this is what the recommendations come from there. So now we have an 18-year-old girl, the same girl with GAD negative. The presentation is not, she is having HbA1c of 10%. So better to start glargine, and after some time you start metformin. On follow-up at 12 months, she has poor adherence. She has gained weight. HbA1c is high, has non-alcoholic steatohepatitis. So in this setting, you need to think of something else, and I will probably add a GLP-1 receptor analog, or maybe SGLT2 inhibitor would be a good option in this perspective. 17-year-old boy with obesity, BMI is 42. So quite morbid obesity. There is acanthosis, family history, HbA1c is very high, high SGPT. So it's a very complicated case. Of course, we are giving everything. Metformin, GLP-1 receptor analog, insulin, what to do. So I think one option which is there, of course, in the last stage is whether a obesity surgery. And it's been shown that bariatric surgery is really curative for diabetes because of all this incretin response. But that's the last stage once you've done everything in that scenario. So to summarize, we should consider type 2 diabetes in individuals who are obese, non-ketotic, and pubertal. Do not diagnose type 2 unless the autoimmune workup has been done. Metformin, insulin, and GLP-1 receptor analog are the mainstay. Add SGLT2 inhibitors. I think pretty much soon they will be approved in India as well in adolescents. So it will be a good drug to use. And of course, Dr. Rishi will talk from here on about how to assess and manage complications in diabetes overall. I think thanks for all for a patient hearing for that.
Thank you, Dr. Bajpai. It was really an eye-opener to all of us that all children are not type 1. So try to find out at least to get, test for everyone. So, and everything is being well explained, nothing to add. So thank you, Dr. Bajpai. Now I invite any question, 1 or 2 questions, quick questions you can take. Please.
SGLT2 has been approved for the age of 10 years. The
Yes.
10 days back only. it has
That's
been
what we
approved.
showed. FDA approval.
Yes, sir.
10 to
For
7.
10, yeah, 10 to
10 to
70.
70. That's what I showed. Yeah.
Secondly, sir, GLP receptor analog also have a cardiovascular safety
Yes,
just
yes.
comparable to the SGLT2 inhibitor.
I think that's a very valid point. Definitely. So I think the key message is that we now have beyond metformin and insulin two good drugs, GLP-1 receptor analog versus SGLT2, and both are very good drugs which have improved the lives of adults.